we test everybody for BRCA. So with the Solo 1 data that came out in the last half of 2018, we had started using these agents, the PARP inhibitors, for maintenance therapy. Um, and I don't think, particularly since the PRIMA data was released at ESMO last year, I think a lot of people who have um, sort of thought about and talked to patients about these agents. The big question is how is it going to impact treatment, in the second line and third line when these drugs were traditionally used, and when is it appropriate to go back to a PARP inhibitor versus and when are we going to use bevacizumab? Of course, the other trial that was released at ESMO was the PALA trial, which was a combination of both PARP, olaparib, and an anti-angiogenic agent, bevacizumab. And those patients did much better, even when compared to the bevacizumab comparator. So it wasn't a placebo-controlled. The control arm had bevacizumab alone. So I think we're beginning to have more choices and more decisions to make in terms of how do we treat patients primarily. And so now it's a question of, do we give maintenance? If we give maintenance, what maintenance do we choose? Of course, we've had bevacizumab approved since 2018, and so particularly high-risk patients would go on maintenance bevacizumab. And now we choose to put patients on PARP, first with BRCA mutations and now with HRD testing. And now it's in all comers. So I think, these are choices, and we have to weigh risks, benefits, even potential costs of these agents in terms of the return on investment. And what do we save for recurrence? And so if you only get, for example, if you can only use bevacizumab one time, is it more prudent to give it up front, or is it more prudent to wait and hold it for recurrence? And I think those are things that are going to have to be sorted out over the next couple of years. And